Good evening. I'm going to talk to you about COVID vaccine effectiveness and the role of booster doses in the fight against COVID. Now, um, we know the world has seen these three waves of the COVID pandemic, and India itself has seen two big waves. And right now, we still see about 10,000 patients every day becoming positive with COVID, and we are hopeful that we will not see another wave of the COVID. Now, over the past couple of years, many variants have emerged with some of the variants having increased pathogenicity and transmissibility, and they've been termed variants of concern. And so if you look at this data from the United States, you can make out that during the start of this year, the pandemic was actually predominated by the epsilon variant, whereas over the next few months, the alpha variant has predominated. By May, it was the alpha variant, and since June and July, it's pretty much been the delta variant, which has actually garnered much of the proportion of the COVID sequences that have been COVID viruses that have been sequenced. Now, if you look at the data from all around the globe, again, since the beginning of June and beginning of July, it's pretty much the Delta wave all the way through. And this is data from the last week, where more than 99% of all the sequences that have been reported are all of the Delta variant. This is from all around the globe. So it does seem like over time, the virus has changed. And right now, the predominant variant is the Delta variant. This is important because when we consider thinking about vaccines, we should also consider how good these vaccines are for the current Delta variant, as well as any other variant that might evolve over the course of time. If you look at vaccination rates all across the world, about 50% of the world's population has received at least one dose, whereas 40% have been fully vaccinated. Contrastingly, in India, even though more than 50% of the population has received one dose, only about half, the 1/4 of the population has received two doses, even though we've administered more than 100 crore doses. So we still have a long way to go with our primary doses of the primary vaccines, before we can think about boosters. However, if you look at some countries in the world, they've gone ahead with their own strategies for booster dose administrations. And like countries like Israel, it's become the norms and it's been offered to the whole population. Whereas in the United States and United Kingdom, they've been offered for certain select groups. Now, we come to today's talk, which is basically, do we need a booster? Now, to answer this question, we need to consider we need to take into consideration a few parameters. One, what's the effectiveness of the current COVID vaccines? Is there waning immunity of the existing vaccines? How good is that vaccine against the emerging variants? What would be the role of a booster against such emerging variants? How safe and efficacious are these boosters? Are they effective? Should we think about homologous or heterologous boosters? And finally, we'll have to think about global as well as national equity and ethical considerations when we think about offering boosters at a time when the primary series has not been fully offered for the entire world's population and also parts of the country's population. So with these in mind, I just want to keep everybody on the same page. I just want to define these four terms. One is efficacy, which basically means the degree to which a vaccine prevents disease and probably also transmission under ideal and controlled circumstances. So this is basically what happens with phase 3 trials, phase 3 placebo-controlled trials, where everything, the conditions are ideal and you get a very clean kind of a data. Whereas effectiveness refers to how well a vaccine performs in the real world. This is often post-marketing data that's obtained from large observational studies, but this gives you a good idea about what the actual value of the vaccine is. Then I just want to contrast two terms. One is booster dose and the other is additional dose. So a booster dose refers to the dose of a vaccine given after the protection provided by the original vaccine doses has begun to decrease over time. Now, booster dose relies on memory. So it's the memory B and T cells which are actually, which have already been primed, which when the booster dose is administered, they provide enough immunity to last for a much longer time. And the immunity this time around, when it is produced, it's actually of a much larger scale than with the primary doses. Additional doses, on the other hand, are given to people with moderately or severely immunocompromised systems to improve their response to the initial vaccine series. So basically, additional doses refer to additional prime doses. And if a person is immunosuppressed, it is likely that just one or two doses of the prime, doses in the prime series may not be sufficient for priming, and they may require additional doses for priming before a boost action can be achieved. So we recognize that there are many vaccines which are under development, and there are about 10 vaccines which are widely in use and are being monitored with regards to their effectiveness. So we'll first look at what is the vaccine effectiveness with the current existing vaccines. This is a study which is done in our own institution, which basically it's done among healthcare workers. I mean, CMC actually employs over 10,000 healthcare workers, and all of them were offered the vaccine, and over 7,000 were fully vaccinated by the time of the study. Whereas 1,800 received one dose and 1,600 were not vaccinated. Now, I want to bring your attention to the protective effect of the first dose of the vaccine and the protective effect after 2 doses of the vaccine. If you look at it for infection, actually the protective effect is about 60%, whether it's 1 doses, and it's slightly higher for 2 doses at 65%. Whereas for hospitalization, again, with 1 dose, it's 70%, 2 doses, it's 77%. Requirement of oxygen, it's over 90%, even after 1 dose and as well as after 2 doses. Whereas those needing ICU care, it's close to 95%, whether it's after 1 or 2 doses. And we couldn't compare deaths because there were so few. And the only death which happened among the staff was in a person who was not vaccinated. I mean, I think it's fairly evident from this that the vaccines are very effective in preventing infection, but more so in preventing severe forms of the COVID disease, which require hospitalization, oxygen care therapy, or ICU care. Now, this is the other study from India, which is from the win-win cohort study from the Indian Armed Forces. They offered vaccination for healthcare workers and frontline workers from the Indian Armed Forces, and they looked at incidence rates among those who are partially vaccinated, that is, those with 1 dose of the vaccine, compared to those who were fully vaccinated, that is 2 doses of the vaccine. And they also actually report over about 95% vaccine effectiveness, either with 1 dose or even after 2 doses. So what about the vaccine effectiveness against emerging variants? This is efficacy data against variants. I mean, I've just highlighted those vaccines which are commonly used. The Pfizer and Moderna are used in the United States, and they have good efficacy at preventing infection or disease for both the ancestral and alpha variants, as well as the beta, gamma, and emerging new variants. Whereas AstraZeneca, on the other hand, preventing infection, it's not so good. But to prevent disease, it's actually still very good. Sputnik, again, performs similar to AstraZeneca. Covaxin, on the other hand, it's probably slightly lesser when it comes to preventing disease and infection. But I mean, like with the other vaccines, its efficacy in preventing disease due to the other emerging variants such as beta, gamma, and delta is actually slightly lower at 68% for disease and 60% for infection. So what we recognize is that, I mean, always the vaccine efficacy is lower for infection, but it's much better for those with disease. Now, that is efficacy data. What about effectiveness when it comes to different variants? This is the UK experience. I mean, so they looked at over 1 million SARS-CoV-2 positive patients, of which more than 20,000 were hospitalized and about 4,500 of them died. Now, if you look at symptomatic disease and if you follow them up over a period of few weeks, and here they've followed them up to 20 weeks, so they've looked at 2 vaccines. One is the AstraZeneca vaccine and the other is the Pfizer vaccine. So the AstraZeneca vaccine, at the end of like 20 weeks, the vaccine effectiveness against symptomatic disease actually drops to about 47%, whereas with the Pfizer, it's about 63%. However, if you look at hospitalization, with the AstraZeneca, it's still at around, its effectiveness is around 80%, whereas the Pfizer, even after 20 weeks, it's more than 90%. And again, if you look at death, with AstraZeneca at 20 weeks, it's dropped to around 80%. With Pfizer, again, it remains at around 90%. So it just goes to show that even though the immunity wanes with regards to infection, the immunity is still pretty robust at the end of 20 weeks when it comes to hospitalization or deaths. So this is just to show about, I mean, so if you look at this, these graphs, which again show vaccine effectiveness against hospitalization in those who are over 65 and those between 40 and 65 years of age. Again, the vaccine effectiveness against hospitalization drops to about 80% with AstraZeneca. It's about 90% with Pfizer. And it's pretty much similar with those who are 40 to 64 years of age as well. However, when you look at those who are clinically extremely vulnerable, the vaccine efficacy drops quite a bit. I mean, it drops to 60% when it is over 20 weeks with AstraZeneca, and it drops to about 70% with the Pfizer vaccine. However, in those who are not in the clinically extremely vulnerable group, even after 20 weeks, the effectiveness actually stays pretty high at 80% for AstraZeneca and over 90% for the Pfizer vaccine. Now, if you look at effectiveness of COVID vaccines against the Delta variant in the UK, whether it's the Pfizer vaccine or the Chadox vaccine, which is the AstraZeneca vaccine, you can see that for the Alpha variant, the vaccine effectiveness is pretty high, whereas for the Delta variant, it's low after the first dose, but after the second dose, it gets to, I mean, it gets very close between Alpha and Delta variants. It's actually within 10% efficacy difference after 2 doses, whether it be the Pfizer vaccine or the AstraZeneca vaccine. So this just goes to show that, I mean, whether it's the variants of concern like the Delta variant or it's the earlier Alpha variant, there is still good protective efficacy with these 2 vaccines. These are the data from Qatar. Now, I'm just showing some data from Qatar and Israel because they've actually vaccinated large proportions of their population, and also they've had breakthrough infections. So I thought I'll show you some data from there. So Qatar introduced the Pfizer vaccine in December 2020, and by September of this year, they had over 80% of their population having received 2 doses. They've had 2 waves. The first wave was predominantly due to the alpha and the beta variants, whereas the second wave is because of the delta variant. And the key thing that I want to highlight here is that a lot of the infections have actually happened in those who've been vaccinated. So these are all vaccine breakthrough infections. Even though a large proportion of the population was vaccinated, they still had considerable breakthrough infections. Now, if you look at the duration of protection after their first dose or their second dose, it's pretty evident that about 14 days after the first dose, the efficacy is about 36%, and this goes to more about 80% after the first few months, and then it drops off, and by around 6 or 7 months, the vaccine effectiveness against infection, it's pretty low at around 20%. However, if you look at their effectiveness against severe, critical, or fatal COVID disease, by 6 months, it is close to 90%. And by 7 months, it has dropped off to close to about 55-60%. So one thing is very clear: even though they've had many infections, it has all been mild infections, and it's not been severe, critical, or fatal infection. So I think that's the key thing. I mean, even though time has elapsed, these vaccines are pretty good against to prevent against severe disease. This is data from Israel. Again, they started vaccination in December 2020. More than 50% were vaccinated with 2 doses, and they had considerable increase in size, increase in their number of COVID positives by June. They had come down significantly by May, but then again, they started to see a rise in June 2021. Now, they looked at their documented infection as well as severe COVID disease based on the time that has elapsed between their second dose and the time of infection. Now, the darker these bars, it means the longer time has elapsed between the last dose of their vaccine. So it's about 6 months. So the darkest bar is about 6 months, and the lightest bar is about 2 months. So you can make out with infection, I mean, this is rate per 100%. So this is in 1, 2, 3, 4, 5. And if you see, it's over 3 per 1,000 persons for people who actually had their vaccines over 6 months prior to this. And as the gap between the time after the vaccine, if it's shorter, their infections are also much lesser. Similarly, with severe COVID again, I mean, here the scale is slightly different. It's actually in 0.1, 0.2, 0.3, 0.4. It's like in decimals rather than in whole numbers, which is there for the infection. So here again, what is clear is if the darker the bar, which means the longer time has elapsed between the vaccine and the infection. So what is clear is that if there is considerable time which has elapsed after vaccination, they are at a risk for infection and also at risk for severe disease, though their risk for infection is much higher than their risk for severe disease. So this is more so in people who are over 60 years of age compared to people who are less than 60 years of age. I mean, you can make out that there is hardly anybody with severe disease in the 16 to 39 age group, and there are very few in the 40 to 60 age group. It's only in the over 60 age group where there is some severe infections. So This is data from the United States, where they've looked at the effectiveness of the Pfizer vaccine up to 6 months. This is actually data from a large integrated health system. This is again a retrospective cohort study, which included more than 12 years of age members of this large healthcare organization. And they had over 3 million individuals which were included. And if you look at their data, 5 months after the 5 months after the time of vaccination, their rates of the vaccine effectiveness has actually fallen down to about 47%, whereas hospital admissions, it's still, the efficacy is actually very good at 93%. So again, it just goes to show that the vaccine efficacy, effectiveness wanes for infection, but not so much for severe disease. Now, what about vaccine effectiveness against infections with Delta variant? Again, after 2 doses, there was 75% efficacy against Delta variant versus 91% for the other variants. But by 4 months, that had dropped to about 53% versus 67% for the other variants. However, for hospital admissions, even at 4 months, it still stays at around 93%, which compared to 95% for the other variant. So even if it's a Delta variant, the vaccine is quite effective when it comes to severe disease. Now, so we know that the existing vaccines are actually good for the variants. They prevent severe disease, not so much infection. With time, it is possible that this immunity will wane even for severe infection. So we might have to consider a booster in the future. Now, if we were to give a booster, are these boosters safe and are they effective? So what data do we have towards this? This is a study from Israel where they've looked at antibody titers before and after a 3rd dose of the Pfizer vaccine in adults aged more than 60 years. So they had 97 participants with a mean age of 70, and 61% of them were women. So this is the pre-3rd dose IgG titers, which is it's about, it's 440 arbitration units, and the IgG titers after 14 days after the 3rd dose, it's gone up exponentially. This just goes to show that the booster works, that the booster does its job of boosting. Now, how about effectiveness data with the use of booster doses? So this is again in Israel, where the population over 60 years of age who were fully vaccinated 5 months earlier were actually given. So a part of them were given the booster dose, and there was a group which was not given the booster dose, and then they were followed up for a period of time after that to see if they developed any infection. Now, this data is actually at least 12 days after the booster dose. So they had over 4,000 in the non-booster group, over 900 in the booster group, and there was a 11.3-fold decrease in the risk of those with booster doses getting infection, whereas this was even more stark when it comes to severe illness. That is, there was a 19-fold decrease in the risk of people with booster doses developing severe disease. So again, this is a graph which actually shows you from the time since booster vaccination, what the protection is like, the factor reduction in the confirmed infection rate. So you can make out that around for the first 10 days or so, there is not so much of a difference, but come 12 days and beyond, there is a significant increase in so much factor reduction in the confirmed infection rate. So by around day 24, between day 21 and 25, it's about almost 15 to 20-fold reduction in the confirmed infection rate. Now, that's using homologous booster. What about mix and match booster? So there was this study which is done. I mean, these are preprints from Medarchive. So this was the study done in the United States where they've looked at primary immunization with Janssen, Moderna, and Pfizer. And to each of them, they actually gave Janssen, Moderna, or Pfizer as the booster vaccine. Now, they had about 50 participants in each of the groups. And if you look at it, what I marked in red is actually those which have got the homologous vaccine, and the others are the heterologous vaccines. So if you compare the homologous vaccines, you can make out that whether it is homologous or heterologous, one thing is clear, that there is the effect of boosting is very good. I mean, there is a considerable increase in the GMTs by day 29. The only thing which I want to bring to your notice is with Janssen vaccine, with the homologous boost, there is less of a boost compared to the heterologous boost. So it is possible that the Janssen being a single dose vaccine, the second dose actually works as the booster dose, whereas for the other two vaccines, there are two primary doses and it's a third dose which is used as a booster dose. So it is likely that it is because of that. Even then, a homologous boost seems to work less, compared to the heterologous boost. What about adverse events if you use a heterologous boost? There were no related serious adverse events, whether it was homologous or heterologous, and pretty much the adverse events that were seen were all the usual adverse events seen after any dose of these vaccines, like arthralgia, fever, chills, headache, myalgia, nausea, and such milder symptoms. This again goes to show the amount of immune response that there is after the booster doses, whether it be heterologous or homologous. The box in yellow actually shows you the pre-boost levels, and the green and the pink boxes actually show you the levels after boosting. So you can make out that the boosting, the effect of the boosting is actually pretty robust, and it's sort of similar across all the groups. So this just shows that whether it be homologous boosting or heterologous boosting, there is considerable boosting which happens with any of these vaccines. Now, there is one another thing to consider, the role of hybrid immunity. We don't know much about it, but there is some information from vaccination after the natural infection, where it shows that vaccination following natural infection is better able to neutralize variants, and the memory B cells which are produced are more potent than the vaccine alone immunity. This is published after vaccination after natural infection, and those who had vaccination without natural infection. So this shows you that it's pretty much similar in between the two groups. Whereas when it comes to neutralizing antibodies, the previously infected participants actually produced better neutralizing antibodies compared to previously uninfected participants. Now, we don't know how well this will work when you've had two doses of the vaccine and then you had a natural infection, and whether you need a booster for those individuals or can you delay the booster. So these are some of the information that we need to study in the coming few weeks or months. Now, finally, we need to consider these global or national equity and ethical considerations. Now, if you look at the global COVID-19 vaccine policy, universal vaccination is only available for, it is available probably a little more than half the countries in the world. There is still parts of the world where COVID vaccination is not available for all the age groups. And there are some parts of the world where only one one select group is actually offered the vaccine, including Afghanistan. So there are parts in the world where universal availability of the vaccination is just not there. And this letter from Nature actually shows you that low and middle income countries still have a long way to go when it comes to the proportion of the population which has been vaccinated. You can make out that the high income countries, over 50% has been vaccinated, whereas in low middle income countries and low income countries, it's still a lot left to be desired. It's low LMIC is only about 10% and less than 1% in low income countries. So with this scenario, I don't know whether it is ethical actually to provide booster doses in certain countries in the world when there are still parts of the world where the primary series has not been complete. So, I mean, I'll just show you some recommendations for boosters. The CDC recommends that anybody who is 18 years or older and has had a Janssen vaccine can be offered a booster after 2 months. And anybody who's received 2 doses of either Moderna or Pfizer 6 months ago, and they should be more than 65 years, and if they are 18 years or older, then they should have some reason, like work in a location that puts them at a higher risk of exposure, or they live in a long-term care facility, or they have a medical condition which puts them at higher risk of severe COVID-19. They've said you can mix and match Pfizer or Moderna or Janssen vaccine. The UK's booster program, they've said adults over 50, people living and working in care homes, frontline health and social care workers, anybody who's between 16 and 49 with a health condition that puts them at high risk of COVID-19, and adults under 50 who are staying in long stay care settings, and people aged 16 and over who live with immunosuppressed individuals. But what does the WHO say? WHO says improving coverage of primary vaccination series should be prioritized over booster vaccination. So in summary, COVID vaccines are very effective in preventing hospitalization, severe disease, and death. Immunity after primary series wanes with the loss of protection against infection, but not so much against severe disease or death. So protection is somewhat decreased against emerging variants, but it is still quite effective against severe disease due to these emerging variants, including the Delta variant. So boosters, whether it be homologous or heterologous, are useful in boosting the immune response, and they are likely to be effective when given. But whether there is a role for the boosters now, maybe not, but in the future, I'm sure there is a role for the boosters in future. With that, I'll stop and be happy to answer questions when